So the next part of our talk will focus on assessing CVD risk. So we've shown that there are multiple factors that contribute to increased cardiovascular disease risk for our patients. And how do we assess this and what can we do about it? So first, looking at CVD risk assessment. So in the US, our current standard of care is using the American Heart Association 2013 guidelines for the pooled cohort equation. And this has pretty much replaced the Framingham risk score in our clinical use. It was based on data from multiple randomized clinical trials in the general population and focuses on reducing atherosclerosis risk in those patients most likely to benefit from statin therapy. So we're no longer treating to a target cholesterol goal. We're treating based on what is your risk for cardiovascular disease. And if you have a certain level of risk, which they've designated as 7.5% or higher, then you should be on a statin to prevent atherosclerotic disease. It estimates, the pooled cohort equation estimates the 10-year and lifetime risk of an atherosclerotic event, which is defined as myocardial infarction or coronary death or fatal or non-fatal stroke. It includes age, race, total cholesterol, HDL, hypertension treatment, which is yes, no, systolic blood pressure, diabetes, again, yes, no, and current smoking, yes, no. It doesn't really include pack years of smoking or any greater definition of smoking history. They identified 4 groups likely to benefit from statins: people with existing clinical disease, all of whom should be treated; people who have an LDL that is higher than 190 or higher; people with diabetes, with an LDL higher than 70; and people without diabetes with a 10-year ASCVD risk of 7.5% or higher. And the pooled cohort equation of note is only validated for people aged 40 to 75 years old. So for some of our younger HIV-infected patients, you really can't plug their data into this cohort because it won't, you can't assess risk based on it. And the DAD study, which I talked about earlier, is this data on adverse drug events in people with HIV, devised their own model that included some HIV-specific risk factors. It estimates risk of CVD event within the next 5 years. The advantage of the DAD model is that it's applicable for people as young as 18, so it goes from 18 to 75 years. It includes gender, age, smoking status, diabetes, family history, blood pressure, cholesterol, but it also includes CD4 cell count. And there's a the composite outcome is MI, stroke, having had a revascularization procedure like a stent placement, or death from coronary heart disease. This is a little bit of a difficult slide, but you see that you plug in age, sex, diabetes, family history, smoker, and they include current and former, the lipid levels, blood pressure, CD4 count. Is the patient on a Abacavir? Have they had PIs? Have they had NRTIs? And they compared it to the Framingham model because that was what was in use at that time. So the advantage of the DAD model is that you can use it for younger patients and you can plug in their HIV-specific information. There are some questions about whether the estimates from DAD regarding Abacavir use and PI and NRTI exposure are applicable with antiretrovirals that we're currently using. And I think that's a question that remains unanswered. But in some studies, the DAD model has performed better than the Framingham risk score. There's some more data coming out now comparing the DAD model to the pooled cohort equation from the American Heart Association, since that's what we're using clinically, at least in the US right now. So looking at how these models work in people with HIV/AIDS, some work has been done in sub-Saharan Africa looking at this. This study done by Mosepele in Botswana looked at HIV-infected adults 30 to 50 years old, so relatively young. They were all virally suppressed. The mean ART duration was just under 10 years. 14% of them had high risk score by the pooled cohort equation, but only 2.6% of them would have had high risk score if the Framingham equation was used. When they looked at carotid intermedia thickness as a surrogate marker for atherosclerosis, they found that 19% were classified as high risk by IMT, and that the pooled cohort equation and IMT classification was similar. So the pooled cohort equation performed better in these participants when comparing it to IMT. Now, the caution with that is that IMT is not the same thing as having had an MI. It is a subclinical marker, and how we interpret subclinical markers is something or about which there is some variability. Using CT angiography, which looks at the coronary vessels themselves, there was a cross-sectional study by Marchella-Zani et al. At Harvard, and they had 108 HIV-positive adults. This is the same group that did the studies with FDG PET. These people did not have any known CVD. Their median 10-year risk score by pooled cohort equation was 3.3%, but 36% of them had high-risk morphology plaques. So 36% of them appeared to be at high risk based on CT scan. And using the pooled cohort equation 2013 American Heart Association guidelines, only 26% of them would have met, 26% of the people who had high-risk plaque would have met the criteria for statin use. So in that group of adults, it's admittedly a small number of patients, it seemed like the pooled cohort equation actually underperformed and underestimated risk compared to CT angiography. Again, not the same thing as having an MI, but CT angiography really does look at the coronary vessels themselves, and people with high-risk plaque are at increased risk for MI. And when we think about what our patients know, what our patients think about their cardiovascular risk, we did a study here that I led at UNC, where we looked at people's health literacy and numeracy and how they perceived their cardiovascular disease risk. We had 162 HIV-positive patients who were 50 years or older. And when we looked at all participants in the gray, and at that time we were using the Framingham risk score. This was in 2014. We had not adopted PCE yet. Using the Framingham risk score of less than 10% in gray or greater than 10% in green, we found that Framingham risk score was above 10% in a significant proportion of our patients. And of those patients, looking just at the people who had high Framingham risk score, only just above half of them perceived their risk score to be high, whereas 42% of them thought that their risk score was actually lower than the actual score. And so we think we're talking to our patients about cardiovascular risk, but we're not doing a great job of communicating to them because almost half of them underestimate their risk.